awareness about epilepsy, a condition that affects millions of people worldwide. Whether you are directly or indirectly connected to epilepsy, your presence today makes a difference in spreading understanding, compassion, and support for those living with the conditions. Epilepsy is often misunderstood, and the challenges faced by those who live with are sometimes invisible to the outside world. But with awareness, education, and open conversation, we can work together to create a more inclusive and understanding environment for individuals with epilepsy. We all understand that epilepsy is a group of non-communicable neurological disorders. And basically, clinical manifestation, if we talk about, is an abnormal, excessive, and synchronized electrical discharge in the neurons. The occurrence of 2 or more unprovoked seizures defines epilepsy. Treatment can control episodes. Urgent medical attention is usually recommended by the health providers. It is very common, and we find that more than 10 lakh cases are there in India. After getting the required lab tests or imaging, treatment can help to manage the conditions. Sometimes family history may increase the likelihood, but so how it affects both and men of all races, ethnic backgrounds, and ages. People with epilepsy are being treated differently in various areas of the world and experience various degree of social stigma due to the alarming nature of their symptoms. Today, we are not really here to learn about epilepsy, but also to acknowledge the strength to dispel myths and work towards breaking the stigma around epilepsy. Everyone deserves to live their life with dignity, and through awareness and acceptance, we can make them a reality. The National Health Authority manages the health benefit packages under Ayushman Pradhan Mantri Jan Arogya Yojana, essentially offering a set of covered medical procedures and treatment to eligible beneficiaries, providing up to 5 lakh rupees per family per year for secondary and tertiary care health facilities, with a network of independent hospitals. These packages, if we talk about, talks about including hospitalization, expensive daycare treatment, pre and post hospitalization care, and through a accessible cashless system. Now, if we talk about neurology packages, we have different packages in different systems and around 15 to 30 packages are there to help the people for this. And altogether is 1,961 packages which are available at NHA. As we move through this event, I encourage you all to ask questions, listen, and engage with the discussions, because we have one of the wonderful speaker today with us here. And that's very important that we say that Arogya Mashram Yashodharyam Cha Metsam Vriddhi Praptin Sayuktam Kritva Cha Swastham Bhav. The shloka highlights the holistic nature of health, combining the physical wellness, mental strength, and prosperity. It encourages balances in all aspects of life to live a fulfilling and healthy existence. We have a very renowned, very special guest who is a Padmashree holder, and Dr. Padma Srivastava, who is the Chairperson Neurology currently at the Paras Hospital, Gurgaon. Ex-professor and head of Department of Neurology, ex-chief Neurosciences Center, AIIMS, New Delhi, honorary professor, UCLA and UK, past president, Indian Stroke Association, author of the Indian Stroke Guidelines, author of the Telestroke Guidelines, task force member for the non-communicable disease division in the Ministry of Health itself, board member for the World Stroke Organization, scientific co-chair for WSC 2016, member program committee for ESO WSO 2020, and faculty for WSO FLP. So when we talk about her, I mean, it's like दिए को सूरज को जैसे दिया दिखाना जैसा है, तो उनके बारे में इसी तरह से बात करना होगा, क्योंकि मैं जितना भी बताऊं, आई हैव सीन हर थ्रू मेनी इयर्स, मैंने खुद अपनी आंखों से उनके काम करने का तरीका देखा है, और बहुत अच्छी बात है कि शी काइंडली कंसेंटेड टू बी हियर विद अस, जहां आप लोगों को उनकी आवाज जो है उनसे जानेंगे कि व्हाट एग्जैक्टली वी हैव टू डू। और इतना इम्पोर्टेंट है क्योंकि मैंने कई केसेस ऐसे बहुत डिफिकल्ट केसेस को उनको उससे निकालते हुए देखा है। तो यू बी माई आई सेल्फ फील प्रिविलेज कि मैंने मतलब हमारी उनसे मतलब वी आर कनेक्टेड टू हर, एंड ये देश का भी बहुत बड़ा सौभाग्य है कि हमारे यहाँ ऐसे लोग हैं। तो मैं ज्यादा समय नहीं बर्बाद करूंगी, बिकॉज डॉक्टर पद्मा हमारे साथ जुड़ चुकी हैं। And Dr. Padma, I would like to inform you we have people from the states, medical institutions, nursing colleges. Even today, we are very privileged to have Dr. P.K. Patra, who is the Vice Chancellor of the Chhattisgarh University. He has also joined. He is a Vice Chancellor over there. And आज उन्होंने भी हम लोग को ज्वाइन किया because आपका नाम और चीजें सुनते हुए everybody wants to join us, and you can see the participants are from the entire country. So the states are also there, the state SHAs are also there. And you'll find कि SHAs के साथ साथ CSC तक से जानकारी लोगों को अगर हो तो सब तरह के लोगों ने इसमें जुड़े हुए हैं. So I'm privileged again, and I'm thankful for your time, because I know you're very busy, very busy. So thank you for your time, and let's start with the session. So I'd like to invite Dr. Padma for her session, please. Thank you so much.
Thank you so much, ma'am. It's such a kind introduction, and seriously, I don't think I deserve all the accolades that you have attributed to me. It's an honor to be connected to you all. In fact, I would say that NHA is a champion currently for our holistic health of the entire nation. I know what amazing and awesome work NHA has been doing, and how it has changed the entire landscape of how health can be delivered at every level, at every sectoral aspect. So it is, God bless you, ma'am, and God bless NHA, and it's an honor to be, here with you. So, ladies and gentlemen, boys and girls, I know I see a lot of young people, and you're the people who are going to, take care of our health as we age now. And talking about an extremely common neurological situation, which is epilepsy. Let me share this screen. Yeah, I think this should be okay. Is that visible to everybody?
Yeah.
Yes.
Yeah, so there we are. So when I'm talking about epilepsy and how important it is, in neurological conditions, they say that the most common life-threatening situation is stroke. And the most common condition which a person encounters in the outpatient as well as in an emergency would be an epileptic problem. So it could be a single seizure, or it could be, dozens of those things happening and leading to altered sensorium, which is called as a status epilepticus, or a flurry of seizures, which can come into an emergency. And there's scores of neurological situations in which epileptic attack is the single event, or it may be connected to numerous other situations in the brain pathology. So as we go along, let's understand briefly, though, what are the conundrums? When I talk about a conundrum, let me get the next slide in. Where is this? Yeah, so I don't have any disclosure as such. Okay, so what is a conundrum? So it is an intricate and difficult problem. And, ma'am Srivastava has put in so succinctly and so well that the problem of epilepsy is not just the disease itself. The problem of epilepsy is not the diagnosis itself. It is also that huge number of stigmata which is associated. Even in this day and time, you still have people dealing with myths and misconceptions of epilepsy, and hence that will lead to huge treatment gap. So the conundrum of intricacy and difficulty is also because of the societal issue we have of dealing with epilepsy. So the definition, again, ma'am has already summarized for you, that if there are 2 or more unprovoked reflex seizures which happen more than 24 hours apart, you categorize it as epilepsy. Also, when there is a one unprovoked seizure, but the probability that there may be another seizure in 60% probability over the next 10 years, then also you categorize as epilepsy. And then you have an epilepsy syndrome. Now, epilepsy syndrome is where a seizure, along with other neurological attributes, you have a seizure and there is a paralysis. Along with it, there is a balance problem, there's a vision problem, there is a behavioral issue, there is a cognitive issue. So that becomes an epileptic syndrome, and that depends upon different age groups. So Seizures would be a transient occurrence of signs and symptoms due to an abnormal excessive synchronous neural activity in the brain, whereas epilepsy would be 2 or more unprovoked seizures more than 24 hours apart. One unprovoked seizure, you have 60% probability of having it over the next decade, reflex seizures, and an epilepsy syndrome. Clear? Now, a seizure versus epilepsy. So every seizure doesn't define epilepsy. And there are epilepsies where the seizures are not in your face. That is, not every epilepsy would have seizures which have generalized tonic-clonic motor movements, and there are jhaag aa gaya, jeep cut gaya. That is not essential to call it a epileptic attack. So there could be epilepsy without those. There could be several other varieties of seizures which may not be generalized. And what's the impact? Again, Srivastava ma'am has very nicely told us that the statistics are staggering. They're staggering, really. So what is the impact of epilepsy? Well, there is a greater impact in the terms of premature death. There is something called SUDEP, which is sudden death in epilepsy. And unfortunately, 80% of all these patients are living in the low and middle income countries. And LMICs, India is still in one of the countries in LMIC. But the trouble of the conundrum here is you have a stigma and discrimination, which involves family, which involves employment, which involves social standing, marriage, pregnancy, or what have you. The whole tapestry of life gets involved in it. So who should who should provide epilepsy care? Neurologists? No brainer. You have 3,000 neurologists in this country at this moment. I think around maybe 3,500, not more than that. And you have 1.4 billion population. And when you're looking at a prevalence of epilepsy of 1 in 100, so it is a physician who needs to be the first contact, and hence the epilepsy gap in many communities need not be because there are no neurologists. Essentially, the physicians have to get into the game board of managing epilepsy care. So let's look at the elephant in the room, because the elephant in the room is an untreated epilepsy. So remember, 70% of epilepsies can be managed by a single drug or maybe 2 drugs, eminently at a district hospital level by a physician. It is only the 30% or a 25 to 30% who are difficult to treat. And in that, you come to neurology care, you come to big tertiary care centers, you have a whole lot of big, a whole armamentarium of high-end investigations and all those things. So the cost for us treating a normal common garden epilepsy is not much. Therefore, I'm going to talk about when to treat, how to treat, what are the anti-epileptic drugs, what are the clinically important issues, when do you have to escalate, and when do you stop treatment in a person with epilepsy. Okay, so we have actually ignored the low-hanging fruit. What is a low-hanging fruit? This is the 70% of epilepsies. So these are medically responsive epilepsy. You just need to give the right drug, the right patient, the right time. That's the adage. Okay, and they do very well at a primary care. And when you have an Ayushman package of these epilepsy medication, you have an Ayushman package of a simple CT scan, that's enough, ladies and gentlemen, to be able to manage 70% of epilepsies in the country. It's only 30% that are drug resistant. You need huge epileptologists and neurologists, neurosurgeons, high-end care, and high-end infrastructure. All right. What are the reflex epilepsies? Now, reflex epilepsies are provoked by a kind of reflex. So you have hot water epilepsy. So it is essentially a phenomena which is rare. So whenever the person is pouring hot water, he gets an epileptic attack, and that's been actually described from the southern part of the country. And more frequently, we have eating epilepsy. Whenever they eat, they have a seizure. So these epilepsies are rare. Their reflex and their management will be a little different. But just remember that there are these kind of epilepsies too. We have the evidence-based guideline. What do you do when an adult comes with the first unprovoked seizure? It's not reflex. There was no seizure. There was no any fever, nothing. He just had one seizure, which is called as an unprovoked seizure. So then they looked into, well, there was a one seizure. What is the probability of having another seizure? Because if you have another unprovoked seizure, then you're defining it as epilepsy. So the risk of epilepsy they seen after 2 seizures, and then they saw that the risk is pretty high. If after 2 unprovoked seizures, risk of third by 60 months is 73%. That's really high. That's the reason after 2 unprovoked seizures, they have to be on medication. Okay? So, but the patients with first seizure, there are other issues to deal with. So here, whenever there is some of these problems, there is a prior brain insight. Say somebody had a road traffic accident, had a head injury, there is some gliosis or some scarring you see on a CT or MRI. You do an EEG and there are discharges. Or, you know, that there is a history. And then there is a CT MRI where there is no history, but when you do CT MRI, there is an evidence of a prior insult or a seizure happening in the night. So when you have these as the first seizure, the probability of another seizure is very high. And in these situations, you have to manage it as epilepsy. Which means that if you don't have any of these, then you can wait. You don't have to necessarily put them on anti-epileptic drugs immediately after the first seizure. But it has to be a dialogue between the clinician and the patient before you take this decision. Okay? So these seizures, you know, they're not epilepsy because there's a very small risk of another seizure. Okay, that is when you have febrile seizures. So that's the reason we call them as febrile seizures. We don't call them febrile epilepsy. This is when there is fever, there is a seizure occurring in a child between, say, 6 months to 6 years old. Alcohol seizures. Metabolic, when there is a low sodium, low calcium, low magnesium, low glucose, or low oxygen. Toxic seizures, when there are drug reactions or there's a withdrawal, there is a kidney failure. When there is a syncope which is very prolonged, that can have a convulsion called convulsive syncope. Acute head injury convulsion, or seizures which happen within the first week of either a brain trauma or an encephalitis, infection, or a stroke within the first week. These are called symptomatic seizures. So these you don't treat it as an epilepsy. However, if they have another seizure happening, then you do. Okay? So the defining timeline in an acute symptomatic seizure is within the 1 week of stroke or traumatic brain injury, hypoxia, intracranial surgery, subdural hematoma, active CNS infection, or an active phase of demyelinating diseases. Okay? But the seizures in sleep are a different ballgame. Whenever a seizure happens during sleep, they have a much higher incidence of a recurrence. Therefore, whenever the first seizure happens during sleep, then you again manage it as epilepsy. And these are the risk factors for recurrence according to their odds ratio. And this I've already, talked about. So I'm going to skip this now. So let's look at a hypothetical case. Okay. Here is a 25-year-old lady. She has 2 unprovoked seizures 1 year apart. Definition: epilepsy. You definitely manage as epilepsy. Another one. A 65-year-old man has a left middle cerebral artery stroke 6 weeks ago and now has a seizure. You manage it as epilepsy. Why? Because this stroke and a seizure didn't happen in the first 1 week. It's not a symptomatic seizure. It's a post-stroke epilepsy. Okay? A 6-year-old boy had 2 seizures 3 days apart while playing a video game. They're flashing lights. So that is photosensitive epilepsy. And here the EEG is showing abnormal discharges. Photomyclonus is, you give these sharp lights during when you record the EEG, and it typically causes these spikes. So this again you have to manage as epilepsy. Now another one. This is a single seizure. A 40-year-old man had 1 focal seizure of left hand, and that progressed to tonic-clonic seizures. And the MRI shows a periventricular dysplasia. This is a gray matter. And you see, usually the gray matter is outside. This is inside. So it's a periventricular dysplasia happening here. And the EEG shows a right frontal discharges. So this, again, even if it is a single seizure, you manage as epilepsy. Here, there are 2 seizures very long ago. Now, this 85-year-old man has a focal seizure at age 6, another at age 80 years. Okay, so this is, he received anti-seizure drugs and then they were discontinued and there have been no further seizures. So this one, you don't manage it as an epilepsy, okay, when there is a long duration between two seizures. Again, a 70-year-old woman had unprovoked seizures at ages of 15 and 70. All right, EEG, MR, family history are unremarkable. Now, what has happened here is, by definition, old and new definitions consider this woman to have epilepsy, because what is an active epilepsy? Active epilepsy is that some seizures happen in the last 10 years and the anti-epileptic drugs have been on for more than 5 years. And I'll come to that when we actually discuss about when to stop epilepsy. Okay. So here also you are going to be a little careful. 16-year-old girl, normal birth development, nothing, no problem, no family history. One episode of generalized seizures. No myoclonus, no abscesses, MR brain normal. What do? Look at the EEG. So what does the EEG show? It shows this kind of discharges. Okay, there's spike and slow wave discharges, which are consistent with what we call as a generalized epilepsy, which is idiopathic, because there is MR is normal. Here's another one, 20-year-old lady, one episode of GTCS, EEG showing this is the 3 to 4 Hz generalized spike and wave discharges. This is the EEG. Okay. This again, all these cases, ladies and gentlemen, you have to manage as epilepsy. So if you have a first unprovoked seizure and there is no proper, the brain insult, EEG is abnormal, CT MRI abnormal, seizures in sleep, you do treat. If it's not there, you wait. If it is an epilepsy syndrome, you treat. If it is not there, you individualize. There are a lot of some people who say that, look, I don't want to have another attack ever in my life. Such people, you may have to institute seizure with anti-seizure drugs. Otherwise, largely, you wait and watch. Or when you have a recurrent seizure, that is epilepsy. Definitely treatment is justified. When do you start? How to start? Which drug? Which dosage? What is the combination of anti-epileptic drugs that have to be used? What are the risks associated? And how long should I give them anti-epileptic drugs? Now the treatment justification, when to start, all that we've already discussed after the first seizure. Obviously, it is true for the next seizure. Which anti-epileptic drugs? When you look at the trajectory of the development of anti-epileptic drugs over a period of now decades, the first, I must say centuries, this bromide was actually a discovery which was serendipitous. Okay. It was actually given for something else and the seizures disappeared. So that's how it came in. Then we have, phenobarbital, and now you have so many more, even beyond levetiracetam. We have now brivaracetam, we have lacosamide, we have so many others. And I will, last couple of slides, I'll tell you even the newer drugs which are coming in, and also combination. So the graph is now full. You have a whole armamentarium where you can actually pick and choose. And that is where you have what is called as a personalized medicine and precision medicine. Which drug is best for that particular individual? So the major considerations when choosing an anti-epileptic drug will be type of seizure, type of epileptic syndrome, what is the adverse profile, the age of the patient, the gender, and very important. There are some medicines, if you give it to a young girl, she'll lose hair, she'll become fat. She's not going to like it. She'll stop the drug. You don't want to give that. So definitely the age, the gender, and the fast and easy dose titration, ease of use, specific comorbidities, especially in the elderly. They're hypertensive, they're diabetic, they're taking so many other medications. How do these drugs interact with them? Plus, of course, the cost. Cost is an important factor, especially when you're looking at newer drugs. Combination drugs are difficult to treat epilepsies. So one glove fit all approach will never work. You must have this as a background information, but a particular individual in front of you is a unique individual. So you must choose the best drug for that individual. So it depends upon efficacy, tolerability, and also affordability. Why affordability? because these have to be compliant. You can't take a medicine today. Tomorrow I don't have the affordability, or tomorrow I can't get the drug. There is no access to stop the drug. You'll have another seizure. Compliance is extremely important in epilepsy. So to diagnose an epileptic syndrome will also be very important, because epileptic syndromes will determine which is the best drug for them. Okay. So in an epileptic syndrome, how do you categorize? You should know the clinical event. Is there a myoclonus? So early morning, young lady, she gets up and she has this kind of myoclonic jerks. She drops things. And then nocturnally, there are generalized seizures that are typical of juvenile myoclonic epilepsy. Okay. So a JME, there are specific drugs which are best suited for JME. And there are drugs you cannot give for JME. So it's important to know the clinical event. Then you're also, helped by looking at the EEG characteristics. Age of onset, extremely important in epileptic, disorders. What is the evolution? What is the progression, and the presence or absence of a family history? So, it's important to also understand, to prognosticate, and also to tell that individual, look, you will be okay, just take these medicines, take for this duration of time. These are the do's and don'ts. Please sleep on time, don't miss the dose. Simple, get on with your life. You should be fine. So when you have a febrile seizure, you give rectal diazepam. West syndrome is a syndrome which is seen in infancy. It is a bad disease, because along with epilepsy, there is also regression of milestones. They lose their milestones. They are extremely the cognitive behavior, a lot of things which are involved in this child. In that, the best choice would be ACTH and vigabatrin. Lennox-Gastaut is another epileptic syndrome which carries a bad prognosis. Besides epilepsy, they have a lot of neurocognitive issues and motor milestone regression. There, the type of drugs are different: valproate, lamotrigine, topiramate, clobazam. This is a benign syndrome. It's a benign epilepsy with centrotemporal spikes. Here, carbamazepine is a drug of choice. And then there are certain disorders which are great, like benign occipital seizures. You just give diazepam in that. Absence epilepsy, you give valproate. JME, which I just talked about, which is again an epileptic syndrome, which is good because it is eminently treatable. And I mean, one can have just be normal the entire life. And for them, we give valproate, lamotrigine, levetiracetam. There are a whole lot of drugs now. So the best first AED, you need to look at an epileptic syndrome. And if it is a JME, don't give carbamazepine or phenytoin. They'll aggravate it. Okay. So it is important, therefore, to know the best first AED. So when I have a JME, which is very common, the reason I'm telling you, talking about JME so much, is such a common disease. You have a 15-year-old, 16-year-old, 12-year-old, young ladies, even young boys who come with myoclonus and a generalized epilepsy. Don't start carbamazepine. You either give them valproate or lamotrigine or levetiracetam or brivaracetam. Then also type of seizure. Is it a partial seizure? Partial seizure can be just sensory. It could be motor, or or it's a primary generalized. That is, at one go, they have a primary generalized seizure. Or is it a partial complex seizure? Partial complex seizure is they lose awareness of their surroundings and they have automatisms. They have some automatisms of the lips or face, or they're just staring at one place. You talk to them, they're not responding to you. And then they come back and they wonder what has happened. They have no recollection. They're partial complex. So you should know what is a variety of a seizure. So when there is a partial with secondary generalized, you can use carbamazepine, phenytoin, valproate, primidine, phenobarbital. But in a partial complex, carbamazepine and oxcarbazepine would be the drug of choice. All types of generalized seizures, valproate would be drug of choice, or ethosuximide. And now we also have levetiracetam. Lacosamide and other drugs have come in a big way in a partial with secondary generalized seizures. We'll come to that a little later. Now, Dravet syndrome and infantile spasms, I'm not getting into detail about this. These are bad epileptic syndromes and entrants. In that, now we have the recent entrant is cannabidiol oil. Cannabidiol has actually come as a drug of choice for the Dravet and DUS and other syndromes. Now, if the seizure cannot be typed, you have the history, they don't know how it started, then you can start valproate, lamotrigine, topiramate, or levetiracetam. Tolerability, valproate, carbamazepine are better tolerated than phenytoin. The reason people don't tolerate phenytoin much is you have gum hypertrophy, you develop hair on the face, the features become coarse, the bones become brittle, and there are a whole lot of other issues. Okay, and the newer anti-epileptic drugs are obviously more costly, but they have their own, advantages. So the real advantage of a newer drug is that will they replace older drugs? They may, because the usefulness is in terms of the tolerability and side effect profile. And there, yes, in some situations, they're very good add-on drugs. So, but otherwise, when there was a scenario, there are big trials which try to compare between different drugs. The efficacy between drugs may not be too much, but again, the major differences are the side effect profile and also the interaction profile. Okay, that's important to us. So the RCTs, the trials which have compared between the, seizure control between different drugs, lamotrigine versus carbamazepine, they found lamotrigine is better tolerated. And they found that in oxcarbazepine with valproate, there's no major difference. There was withdrawal was more in phenytoin. And gabapentin is a very, very mild anti-epileptic drug. It's useful mostly in people where other drugs are contraindicated or in geriatric population. Okay? But when do you go to a new anti-epileptic drug? According to the NICE guidelines, if established drugs have failed, or the most appropriate older drug is contraindicated, or they're interacting with other medications, or there is a poor tolerability. But however, what we see these days is the moment a new drug, anti-epileptic drug comes, the practice is you jump onto the newer drug, and what is available with us, say in AIIMS package, we have all the older drugs with us, which are very good. Phenytoin, carbamazepine, whether it's phenobarbital, all of them are there. But people first go to lacosamide or topiramate, which are costly, and it may not even be indicated. So you must know when to start a newer drug as well. Okay, that's important to us. Now, the broad spectrum anti-epileptic drugs are these: lamotrigine, topiramate, levetiracetam, clobazam, and the newer drugs for generalized seizures are lamotrigine, topiramate, zonisamide, levetiracetam, brivaracetam, whereas the other drugs would be less important. But in JME, please remember valproate is superior, and then you have all the other drugs out here. And lamotrigine, I'll give you a couple of more issues on lamotrigine, because lamotrigine, when you start very small. Okay, you just start with 25 milligrams, and you have to look out for rash. And when you prescribe, you must tell the individual, look, if you develop any itching or rash, immediately stop. Because lamotrigine can cause very bad allergic syndromes, including Stevens-Johnson. Okay. Now, this is a sort of a repetition to what I've already said, but when you look at the guidelines for a new onset partial seizure, the newer drugs, you can have lamotrigine, oxcarbazepine, topiramate, and also levetiracetam, brivaracetam, zonisamide. Tigerbalm is not available with us right now, so it was there and it went off, so I'm not going to talk about it. And in partial, all of them, including zonisamide, is pretty good. So when you look at the efficacy spectrum, absence, myoclonic seizures, valproate. Remember, myoclonus, valproate, then ethosuximide, then levetiracetam and brivaracetam. But when you have a broad spectrum, all of them you can use. Partial, you always start with carbamazepine. You may have phenytoin, oxcarbazepine, then go on to the other drugs. Only absence best is ethosuximide, and that's available. Okay, so the well-tolerated drugs are these. If I have to mention about levetiracetam, the one problem with levetiracetam, and to some extent even with brivaracetam, is mood effects and personality changes. Sometimes it becomes pretty difficult. They're suddenly very angry, or they become brisk, or they become more depressed. It sort of brings out its innate personality. So you must take that into consideration. Ask them if there is a problem. Then how long does an anti-epileptic drug take effect? Now, this is the pharmacokinetics of the medication and the half-life, and how many days it is required for the drugs to start acting. So a lot of times we load them up and then put them on the oral drugs, because otherwise it will take so many days for the drug effect to start. Wrong selection of drugs can cause seizures. That is something which you should be very, very careful about. And I told you, very commonly when there is myoclonus, never give carbamazepine. Okay. The paradoxical effects is also known. Sometimes lamotrigine as well as levetiracetam has this peculiar situation. You keep giving the drug, the seizures become more. Then you should be aware that these are drugs, sometimes they themselves cause seizures. So taking a history and taking into consideration how good the seizure control is important. A continuous dialogue when the patient comes back to you, not just repeat the prescription. You need to engage in a dialogue and find out how they're doing. Okay, and it is known lamotrigine, all of them have this capacity also on the flip side to cause seizures. Now we come to more than monotherapy. So when do you think you need to start polytherapy? Remember, monotherapy controls seizures in 60% of cases. Just that it has to be the right drug at the right time to the right patient. Okay. But when two monotherapy trials fail, you start polytherapy. And after the initial drug, there is also a situation where what is a second monotherapy and what is the drug which you can start on. So if you have a valproate not controlled, then you add on levetiracetam or zonisamide. That's how which is the next best drug, and then you can add on that particular drug. And for focal epilepsy, again, you're starting with carbamazepine, oxcarbazepine, and then you can add on lamotrigine or levetiracetam or even valproate. And there are real guidelines all there. You can actually Google it and also show whether it is American or Indian or international. So all of them probably do say, they all speak similar language, that there are drugs for partial seizures onset, there are drugs for generalized seizures, and some who will act for both. And all these drugs are freely available with us. Okay. Now, let's come down to the Senate study, which is an older study. But we did compare all of these, and in a real outpatient clinic in the UK, and they found out that the older drugs are not really bad. Okay. But it is important to understand that you should not be jumping into the newest anti-epileptic drug just because it has come new to the market and some medical representative has come with this prescription. Okay, look, this is a great drug. Start with the drugs which are available. Cost is a major factor. Try and use medications which are there available free of cost to the individual, because compliance is very, very important. Out of pocket expense of all these medications will be horrendous in certain sections of our society. And epilepsy is all pervading. It happens all sections of the society. Okay. So in polytherapy, which drugs can be add on? Valproate, you can add lamotrigine, topiramate, levetiracetam, or zonisamide. When you have, in sometimes the next one, let me come to that. When it carbamazepine, you can add levetiracetam, lamotrigine, topiramate, zonisamide. Okay. And are specific combinations useful? Yes. In absence, use valproate, ethosuximide. Myoclonus, add valproate, clonazepam. Partial seizures, add carbamazepine and vigabatrin. Partial, generalized, or JME, when you are in doubt, get valproate and lamotrigine. Okay, or even valproate and levetiracetam. How do you compare drugs is what we have been talking about. But there's a little bit of a science which is also involved. Okay, avoid combinations with similar mechanisms of action. Something which is acting on sodium channels, both carbamazepine and say phenytoin, don't combine them. Doesn't make sense. Different mechanisms of actions, they would be better be combined. And if the combination therapy fails, we're looking at the 25-30% of that little cohort of intractable epilepsies which are surgical, where you need to go into excision, different varieties of intervention, brain stimulation, nerve stimulation. There you're getting into another completely different ball game of intractable epilepsy surgery mechanisms, and also all the investigations, those are different. And then we're not going to talk about, we're talking about common garden variety of epilepsy. Okay. Now let's come to the getting the dosage right. Dosage right is also important, as important as choosing the right drug. And you need to dosage tailored according to individual needs. There is one thing my professor used to tell me. So doing a drug level and deciding on the drug dosage is like driving a car on the road, not looking at the road, but looking at the speedometer. You don't do that. So drug levels are important when you're giving a right amount of dosage, still the drugs are, the seizures are not controlled. So you don't know the compliance. You see, drugs don't act for people who don't take them. And so to look at a compliance, you can look at a drug level and see drug level is low. That means the guy is not really taking the medication. That's the reason seizures are not controlled. The second thing is when there are toxicity, there are side effects. Then also you can do a drug level and monitor them. But routinely doing a drug level and saying if everything is under control, then you don't have to, change the dosage. And then there are risks of course associated. There are a lot of side effects. Let's say, for example, the quality of life, cognition, mood, psychomotor, sexual dysfunction, cosmetic effects, bone health, weight gain. All of them you need to consider. Okay. So in an anti-epileptic drug treatment, failure to achieve a complete seizure control, maybe because of dose dependency and side effects, idiosyncratic reactions. As I told you, with lamotrigine, you have this Stevens-Johnson syndrome, adverse effects which can be mild or even moderate. Phenytoin, osteomalacia, and felbamate was a drug which went off. It has come back with a black body, that is aplastic anemia. Vigabatrin is visual field defects. Topiramate is raised intracranial pressure. And then, as I said before, levetiracetam, mood and behavioral changes. Okay, zonisamide can cause mental slowing. So one should be aware of these side effects. So if somebody comes and says, I've started this drug, my seizure is under control, but I have these problems, doctor, you have to look at this. Maybe it is drug induced. Brivaracetam is now I don't think it's a newer drug anymore because it's been in the market for a long time. This has come in place of levetiracetam for, again, when there are a lot of mood changes, but brivaracetam also can cause mood changes. Eslicarbazepamine sometimes can be given in place of oxcarbazepine. This has an improved tolerability. The responder rate is a little higher, but most often it is given as a once in a day dosage, so compliance is better. Lacosamide is now being used right, left, and center. But what I'm a little worried about is when they come in the practice, I see these prescriptions. You have as the first responder, one seizure, there are lacosamide. You don't have to do that. You don't need to start two drugs. But lacosamide is a good adjunctive therapy for partial onset seizures. Okay. Now, the emerging drugs include carisbamate. Let's not getting into that detail. Retigabin. These are all going to be probably coming into the market because some of them have completed their even phase 3 studies. Rufinamide has been there for a long time now. Stiripentol. They are not there in our Indian market, but these are all the drugs which have phase. They may be coming into the market soon. But on the horizon are all these drugs. So you see the reason there are so many trials is because we don't have a magical therapy. We don't have the best drug for all epilepsies. So the quest continues, Now people will come and say, when do I stop? No, you stop the medication when you have to look at the probability of a relapse if I stop the drug, presence of adverse effects, psychological attitude, and other implications. Okay. The recurrence risk of all types of epilepsy after 2 years of seizure-free period is around 30%. And maximum recurrences occur in the first year itself. So if a patient is seizure-free, you stop the drug, 2 years, nothing has happened, then the probability is very low. It may still happen, but that's very rare. But what are the factors for a high recurrence once you stop? Abnormal EEG. So you must do an EEG before you're considering to stop. Known structural lesion. Like you have, say there is a stroke, there is a big gliotic area, there is a road traffic accident, big gliotic area. Occurrence of many seizures before control. Long duration between therapy and seizure. When there is a treatment gap. More than one type of seizure. Adult onset complex partial seizures. Now these, ladies and gentlemen, are a tricky business. Okay. So these are the problems. When you have to look at these when you consider stopping the because patients would love to stop drugs and they'll tell you, oh look, 3 years I've not had seizures, so please stop. So between early versus late withdrawal, they've seen that within 2 years, if you stop drugs, relapse rate is higher. So you're not stopping that. The most important predictors for relapse rate is the myoclonus. When there is a myoclonus, symptomatic partial syndromic seizures, they relapse. So don't do it. So in JME, the relapse rate is 95%. So that's the reason in JME, when they're well controlled, I'll tell them, I will, reduce the dosage. I'll come to a little small, dose, but I'll let it continue. Okay. And sometimes they're not happy, but that is the best protection they can get. Similarly, when you have seizure on awakening, symptomatic partial, but when you have benign seizures, the probability is much, much less. Good prognosis in febrile seizure, benign Rolandic epilepsy, just an absence seizure, and idiopathic generalized tonic-clonic seizures. Poor prognosis in complex partial, symptomatic partial, minor motor seizures, and the onset in infancy or puberty of generalized tonic-clonic seizures. So epilepsy is considered to be resolved for those individuals who have an age-dependent epilepsy but are now past that applicable age and are seizure-free for last 10 years and no seizure medications for 5 years. Okay, simple. You have been seizure-free for 10 years, no anti-epileptic drugs for 5 years. That means you do not have an active epilepsy. And if it is not an epilepsy syndrome, but even if it is an epilepsy syndrome but is age-dependent, like you have this benign Rolandic epilepsy or the benign occipital lobe seizures, they only happen in that particular age group. You're an adolescent or an adult, you're not going to have that, so you can stop the drugs. So don't use words cure, because there's probably, you can't say cure of any disease except infection. So resolved, no longer present, doesn't guarantee epilepsy will never come back. But you can always use something like it is active versus inactive. So you can say that, look, now epilepsy is very inactive. You probably are not going to get seizures and we can withdraw the thing. Okay. So here, this is a normal EEG. Patient had a seizure, generalized tonic-clonic convulsion, single. He was on anti-epileptic drugs. At that time, EEG was abnormal. 2 years, no recurrence. EEG is normal here. Then, and the MR had shown a tiny calcific lesion. So this is one where probably you can offer that you can withdraw the anti-epileptic drugs. But if there are seizure episodes happening in, these are the discharges which are there on the EEG, do not taper anti-epileptic drugs. So when there is an EEG abnormality, do not stop. So cryptogenic epilepsy, where you don't know the cause, like there is no calcified lesion, there's no gliosis, there is an increased risk. When there are spike and slowing, there is an increased risk. So do not stop, anti-epileptic drugs. So this is sort of summarizes the traumatic brain injury, post-traumatic seizures. Early, probably few weeks. Late, you treat as epilepsy. When there are no seizures, mild TBI, no prophylaxis needed. Sometimes people give anti-epileptic drugs for about a week. Similarly, for stroke, symptomatic seizures, no seizures, no role for prophylactic anti-epileptic drugs. So very often I see acute stroke, they're on anti-epileptic drugs. No need. Okay. But when there are seizures, early seizures, I would definitely try and treat it for a few months. Late, you must treat as remote symptomatic epilepsy. Similarly, the infection. Now, neurocysticercosis is probably the commonest CNS infection that you encounter, especially when they come up with a single seizure or a couple of seizures. In the almost 10% of epilepsies which come into the OPD have the cysticercosis there. So it's as important there. So in NCC, when it is still active, you definitely manage it as epilepsy. Fibrocalcified, you still treat it as epilepsy. Okay. So that is the end of my presentation. I hope I've not confused you all, more. The theme I really wanted to, get across to you is, the seizures as such are very common. Every seizure is not epilepsy. When you have to diagnose epilepsy, you should also realize that there are certain number of mandatory tests, which includes neuroimaging and an EEG, and they're very simple anti-epileptic drug protocols that you can employ. And 70% of cases, You can just manage this epilepsy at a district level. No need to even send them to high-end infrastructures. Simple Ayushman Bharat packages at this point of time will treat 70% of your patients with epilepsy. I'll stop sharing, and any questions that you may have, please let me know. I'll be very happy to answer.
Thank you so much, Dr. Padma. And now it's the question time. So those who want to, I mean, I could see some hand raises, but any question which strikes you, please ask the questions right now.
Any questions from the participants, they may write in the chat box or they may can raise their hand so that we can unmute from our side.
What we can do also, ma'am, is that in case they would want to, write an email or something, then we can also answer by emails later.
Ma'am, can you share your email ID on the chat box?
Yeah, that's the same email that you all
Okay.
have.
Okay.
Yeah.
Okay.
So thank you, ma'am. And we have Vice Chancellor, Medical University, Raipur, Chhattisgarh, Dr. P.K. Patra, who has also joined us. We'll request, because he was saying he was very enthusiastic to hear from you. So I think, Dr. Patra, are you there?
Yeah,
sir?
yeah. Thank you, madam. It's I think thanks
Thank you,
to
sir. Thank you,
Dr.
sir.
Padma. It is a excellent input to the newcomers. If you see this, as you told and Srivastava madam also told, this is more. This all the epilepsy patients. They are the social stigma has to be addressed, and at this replacement of this new knowledge and how to combine the medicine and things. Different combination of anti-epileptics. This is a very excellent replacement. I think that will be the new doctors and those who are started practicing now. For a veteran, it may be repetition, but I think it's an excellent initiative by the NHA and the Dr. Srivastava. Is this type of activities she used to do, and I extend sincere thanks to the Srivastava madam and the obviously congratulations also. And I think this is the very good initiative and very good webinar also. And I think they have chosen excellent speaker and Dr. Padma, I think. And it's from my side, I think my university also. And I had a question so that whether it will be helpful to the nursing student, or because our university is also associated with the nursing, allopathic, Ayurvedic, homeopathic, all these fraternity, because it's a total medical science university. So I think I forwarded this information to all they might have joined. So I think this type of lecture should be organized by the NHA. I think it will be very good in future also. Thank you
Thank
very
you,
much.
sir. Thank you, sir. What I can do is to share this presentation to Vinita ma'am, and maybe the information there can be given to everybody. They can also see that. So I can do that, ma'am.
There is a question that can people with hemophilia suffer from epilepsy? What will be its treatment, please?
Yeah, so it's a great question. So hemophilia by itself is not going to cause epilepsy. But when you have hemophilia, you have a tendency to, bleed. So any small kind of an injury, like, a lot of hemophilias come with this knees are swollen because, they bleed into the knees. So if there is a bleeding into the brain, if there is a hemorrhage and you have an injury, now that can cause. But hemophilia by itself, a factor 8 deficiency is not going to cause epilepsy per se. So not as a bleeding disorder, but because of a bleeding disorder, if they bleed into the brain and cause an injury, that can cause epilepsy.
So hope संतोष कुमार जी आपका क्वेश्चन जो है आंसर हो गया है. Anybody else wants to say?
They can raise their hands or they can write in the chat box their questions.
So the mail ID is also being shared. If you want to ask her questions directly, it will be easier. And you can write, because the mail ID has been shared by the capacity building division, you can see, and you can write the mails directly also if you want to connect with her. Because if, some people were talking to me and writing on my chats that saying that we want to connect directly. I said, okay, fine. So we can also, I mean, this is the way you can connect with Madam directly also. Anybody else wants to ask any question? Any questions, please? From the states, especially people who have drawn from the PSCs and CSCs. I can see Yavatmal, DVMO, and CSC Binavar. I can see from Binavar Badayu also, Shraddha Gangwar, Anuradha Vats. So anybody wants to ask any question or there are any confusion, just let us know, or the mail IDs are being shared. You can always connect to them directly as well. But ma'am, this presentation, I don't know, it was very technical, but for me also it was very inspiring. Actually, you'd come to know so many things.
I'll send you the presentation, ma'am. I'll share the same.
Mhm. So this will be very helpful. I mean, I can see people from different places who have joined, and this is going to help. I mean, we will share the presentation to everybody. So, and ma'am, if you permit, we can share this presentation to our medical superintendents across.
Yeah. I'll send it to you. I mean, the same email which has sent me the link. I'll send it on that. Please be free. आप जैसे भी आप चाहिए वो आप use कर लीजिए. No issue.
ठीक है. Thank you, ma'am. Thank you for your time and your
Thank you, ma'am.
presence as well. Thank you so much.
Thank you, ma'am.
Meanwhile, we are sharing a feedback form link in the chat box. Please fill the feedback form, and if you do have any queries in for the concerned session, you can also write in that feedback form. So a feedback form has been shared in the chat box. We can rate the session, or if any further session you just want to have from NHA, you can also write on that feedback form. So thank you so much for thank you everyone for joining from the different corners of the country, from doctors, of medical students, and from SHAs, those who have joined, and specifically to Vinita ma'am and to NHA, and simultaneously to the Padma ma'am who has joined and taken this session. Thank you everyone for joining. Thank you so much.